All right. Well, now we're going to continue with the interview with Dr. John Shaw, orthopedic surgeon, and as well as a rehab physician who works with tetraplegia hand. Let me go to the next question after that because this is important. Can you tell us, in order to be successful, what type of pre and post operative evaluation do you carry out, that you do for to secure success?
Well, that is a very valuable question because again, I want to introduce surgery to them very carefully, very slowly. I'm never going to tell them early, you're going to need surgery, but there comes a point in the evolution of the rehabilitation that restoring their hand function for the patient is probably the most important thing they gain. I don't know how it compares to bowel, bladder, walking. They're all very important. But
for high tetraplegia is one of the highest.
Yeah.
So
yeah, so I think I gradually, again, I emphasize over and over to the therapist, be preparing these arms as if they're going to have surgery, because the more supple you can keep the arm, the more soft it is. Now, when you get bombarded by spasticity, that's like the big enemy that attacks you. And as you know, trying to deal with spasticity in the upper extremity, which is a nightmare sometimes.
Yeah, it is a nightmare.
And it is a really tough one. Now, you can deal with the spasticity and still do it. And even when we were doing electrode implant, some people with spasticity actually did better with the electrode implant than the other ways. So what I do is I gently move them down the line and they start hearing about it, and they are gradually, they're going to finally come to the level where you say, okay, they're not going to get better. This might be a year, this might be 2 years. It all depends on how they progress in the whole area of their spinal cord recovery in terms of bowel, bladder, sitting, transfers, all those other things. So I gently guide them into that direction. I really emphasize the range of motion and the strength through the shoulder, through the elbow, through the wrist, hand, fingers, thumb, opposition, so that you try to have everything like you've set the table for the meal. Okay, you're going to bring the meal on and you got the utensils, everything there ready to eat. So, like I say, if it appears that they're going to kind of level out at that C5 level, but you're saying international classification of 3, then I really want to know what their nerve studies are going to be. Are they a candidate for a nerve transfer to open their hand? And that's when because you have a window there, if that injury is at the level of their injury at the spinal cord, and you don't transfer that nerve into that nerve that's been affected by the anterior horn cell, you may lose the opportunity to reinnervate that nerve. So that's where you have to have a golden opportunity to know, I can do this. Now, if they're below that level, if they have a intact nerve below the level of injury, you could do this 5-10 years later with a nerve transfer, and it would work. But oftentimes, like I tell people, the sooner that you work with them and educate them, the sooner they're going to be learning how to do this. But if you wait for a person a year or 2, they learn so many techniques to do them. And I've had patients that would be perfect examples for tendon transfers that will not do it because they've learned so many adaptive techniques that they would lose. They think they can do it better. And sometimes they do. So you just have to listen. The dynamics of these families, just changes by the day, by the week, by the year. And the person you think would be the less likely to benefit, a year later may be the ideal patient. So you're preparing.
What you're saying is preparation means
preparation,
good therapy
critical
from the beginning, starting from the acute phase, which we have all the inputs, bad inputs, good inputs to the spinal cord, to kind of get the advantage of getting the good outputs from the spinal cord, which is new movement instead of the spasticity and the pain, all the craziness happen after spinal cord injury. Is that what you're saying, kind of?
Yeah, you're walking together with you. I'm walking with you as you're doing all those other things. And we're just, coming together sometimes, some lady apart, but you're a team. That's what I love about rehab. It's a team. That you're doing this together. You're not just saying this is a silo for surgery, or this is a silo for bowel or bladder or skin or contracture or walking or whatever. It's spinal cord lends itself better than any other thing, I think, in rehabilitation to that kind of team concept. And the therapists have to be there from day one and never leave. From inpatient, that continuity flow right through the outpatient, the rest of their life. These are your patients for life.
So where's the key of having a good, you have many good therapists with you around all these years. How do you develop that? They're very good OTs, who knows, they know about neurorehabilitation, but how do you mentor them? Because this is a very specific, unique niche.
Oh, that's a good question. And it's just the more you get to know them, as I work with them, as I see them, and as I see them respond to what I'm talking about, when they start asking questions, when they start showing me the splints they're making, and I can say, okay, you need better extension on this. You need to include the thumb. You need more opposition in that thumb. They get a savvy about this, that they get excited about it. Now, if you are lucky enough to find a therapist that has those unbelievable skills in making splints, that's golden. I had one therapist when I was at Southern Indian Rehab. She was a hand therapist, and I really didn't think, they say, oh, I can make a splint. She came back with a splint that blew me away. She just had it. And some therapists, it may be a OT aid. Who knows? There's some people that have that just ability to take that piece of plastic. They can mold that and make it look like a piece of art. And they want it to look like a piece of art. Other people will cut it out, be rough. Oh, okay, it's serviceable. But you just keep looking. You keep, if you have that big pile of manure and you dig through it, you'll find a pony in there somewhere. So you're gonna find that therapist in some place you never expect. It might be in the stroke service or some other service. You keep looking. And if you find them, bring them aboard, grab them and hold on to them. Because they will grow, they'll be excited.
So it doesn't matter, how long, if we get there early, the better, but any pre-surgical treatment that you recommend before going to we dive into the surgical portion of it?
There's no surgery that you're going to impound on them early. You have this all in your mind. You know where it could go. You're watching and see. And now another really important facet is just knowing the body habitus of the patient. If they're real muscular people, about 20%, I don't know, what would you say, 20-25% of spinal cords are women. What are you saying now?
Say that again.
About 20% of spinal cord people are women.
Oh, yeah, yes, majority of men.
So the thing is, in women, oftentimes, the kind of works they do, and now with the computer, patients want, if they have had a spinal cord for a long time and they happen to be in a category where they extend their fingers, being able to extend their fingers to work on a computer, you have to really be aware of it, because you can't always maintain as good extension as you want. That's the beauty of nerve transfers, is that you can get that individual extension of the fingers. And so you really need to kind of watch where they're going vocationally and everything, so you really look at these hands. Some of these hands are stubby, short. They got really short thumbs, and you're looking to see what kind of opposition they have. I remember one young woman had really, and even a couple men, they have really long, slender hands. And they are balancing those hands is different than if you have a short, stubby hand. And so all of those criteria are something that you keep in your mind and are watching, and the therapist is watching, because there's no two hands the same. And you may have a little contracture of one finger, or you may just have some tightness of the MP joints. So all of your processing is towards just constantly evolving that person towards, well, okay, now it's time to start thinking about what we're going to do in terms of anything surgical. So you have to be a good observer of how they use their arms, what they've done with their arms before. Are they right hand dominant? How they're using their hands. We used to do videotaping of the patient with the therapist, and we had them do all kinds of things from the telephone to everything practical we could do to see how they use their hands or how they would use their hands in an adaptive way. So that's that observation quality, particularly among therapists, is so critical.
So doing that, everything you mentioned, how much increased success rate? I mean, everything that you do, I mean, I'm not asking you specific data, but in your experience, all the stuff that you do in preparation, how much that translate in success? 50%, 60%, 70%?
How much does that translate into what?
To your success in these patients.
Oh, right, 100%. Really, I'm serious.
I knew you were going to say that.
I mean, that is so important. And that's why it takes a lot of time. I mean, just doing a piece of surgery is just a little piece of that. Yeah. I mean, to me, it is all the preparation, all the person, and helping them see, okay, this is what you aren't going to do this. You're going to do this. I have a patient right now as bilateral. They can do a little bit of this. They're not ready to do that. And I don't know, they may be ready, maybe not, I don't know. But you just have to embrace them where they are. And okay, this is the time we're going to do surgery. And then, so it never ends, that, and the therapists that can watch them that way with you, they're golden. They're just so valuable to you. And that transition from inpatient has to be, that's why I really like when we'd round and we'd have the inpatient and outpatient. They need to have that integration. And when I'm doing these things with the therapist, they're bringing in the inpatient and outpatient therapists together, and they feel like they really together, they're integrated, and they're not just silos of therapists. That's the beauty of it. And the thing is, when they go home, it's so important that you're teaching that family member, hopefully a wife or a spouse, a sister, that can, because when they're in therapy, maybe they get a half hour 3 times a week. Well, that isn't a lot of time. So you really have to educate the family and hope you have those caregivers that can really give you that kind of.
So just to summarize, before the surgery and to prevent when they are getting close to your surgery and after the trauma, the event, we have to make sure there's controlled edema. Make sure we control the spasticity, right, range of motion, family training, and then you come on board to make sure the classification is done and determine whether or not this patient qualify for a tendon transfer or a nerve transfer. Is that correct?
Right.
Okay. So now let's move to after surgery. Talk to us about the post-therapy evaluation, post-op evaluation. What do you consider after that? And what type of rehabilitation you offer to these patients?
Well, this again is a continuity. It never ends. So that piece of surgery is just an integration of something that never ends. That's why it's so important to maintain your team. So if it's the beauty of now, let's say if we're going to do a nerve transfer, the beauty of nerve transfers, they're out about maybe 2 weeks. And then they can go back to therapy, full therapy, once that wound is healed, no limitation, but you just have to wait, several months to see what happens and see what kind of strength you get. So that's one thing. So the nerve transfers, when you decide that's your option and that's the best option, you can do it as early as you want to, and you won't interfere with the therapy. Now the tendon transfers, when we're at that point where we are ready for that, the beauty of that is now that with the tendon transfers, usually we do 3, there are basically 5 parts of the arm. One is they have to have a shoulder. And so we want to give them elbow extension. So the international classification is 3 things. It's one is that 1, 2, 3, 4, 5, 6 tells you the muscle level. Number 2, we use what we call sensory. We use a little c, a big C, little u. And that means they have to have sensory sensation that they don't have to look at their hand, which wasn't true in leprosy. If you have to look at your hand to see your hand move and you lack sensation, it has to be less than 10 millimeters of 2-point sensation on the finger. What do I use for that? I use a paper clip, 10 millimeters, pull it out, touch it. It's a simple thing. Thumb, if they have a thumb, okay. Usually we require the thumb and index finger. We're trying to get a key pinch, not a tripod pinch, a key pinch. So that's what we're trying to achieve. So we want a good pad. We want a sensation on the thumb if possible. We like the sensation over here on the index finger. So we're trying to get elbow extension. And so part of the classification is the 1 through 9, the sensation, and then for triceps, we put T plus or minus, because triceps is multi-level. So if they can do against gravity, I will usually say, if they can do out here without gravity, I'll give them a T minus. That tells me they've got triceps, but they don't have this kind of triceps. So I fudge a little bit. I do a plus or minus. The same way, if I'm doing a wrist extension, I may say 3 plus, but they don't have a pronator, or I may say 3 minus. So we're trying to give them an elbow extensor, which we would do a posterior deltoid to triceps transfer. That the recovery from that is about 4 to 6 weeks now. We put them in an extension brace and we allow them at about 4 weeks to come out, about 10 degrees, lock them out at full extension at night, allow them to flex about 10 degrees every week. So in about 6 to 8 weeks, they're extending the arm using the brace only at night. That's a little longer process. The next phase is to open the hand. So if we're opening the hand with a nerve, okay, we've already done that. If we don't have a nerve transfer, we don't have any tendons to open the hand. Usually we only have 2 tendons, maybe. So we're trying to give them opening of the hand is, if we can't do it nerve transfers, we have to do a tenodesis. Now you can do what we call an extensor phase and flexor phase at the same time. Traditionally, I did an extensor phase where a tenodesis of the fingers and thumb, and they would begin usually at about 3 weeks, already begin opening. They could open the hand well like this. But when you add the flexor phase, in the flexor phase, that is a transfer of the extensor carpi radialis longus to the finger flexors, brachyradialis to the thumb flexor. That gives you finger flexion, thumb flexion. The thing you have left is opposition. So what can you use for opposition? That's always a dilemma. If they're a level that they have finger extension, you can use the extensor indices minimi. You can use the extensor indices proprius if you have it. Those are 2. And if rarely, if they have a wrist ulnar flexor, you can take a piece off the ulnar wrist flexor over here for an appendoplasty. That's ideal. That's down the international classification of a pure C7. So that's what you're trying to do: elbow extension, finger and extension, finger flexion, thumb flexion, and thumb opposition. The other option is doing what we call a carpometacarpal fusion. And I have never liked it very well because I like a hand that's mobile. But if it's not something we don't not do, and it does give you power. So we know that nerve transfers don't give you the same power as tendon transfers. But the nerve transfers are really good for giving you a hand that's not as strong, but very functional. The recovery after tendon transfers, we put them in a dorsal splint. We begin moving now with the kind of suturing we do now. We begin moving them that first week, and they start moving the hand. And by 6 to 8 weeks, the splint's gone. They're starting to use the hand. By 3 months, they're allowed to be full function. So, but we want them to actually start moving the hand almost from day 1 with the tendon transfers. Unlike in the past, before we had the kind of suturing we have now, I would wait 3 weeks to start the motion. So we try to educate them what to do, what to expect at that time, because they're going to be afraid after that surgery. Oh, I can't move my hand. But when they discover it, they just, I can do it. So and the other piece is what we call the intrinsic, because oftentimes they don't have intrinsic. So sometimes after you do that, you get kind of a claw hand like this. So there may be a procedure that you can do to give them intrinsic function. Traditionally, I've had my patients have used their hands so much that over time they tend to stretch out that, if there's somebody that's a rower or plays rugby, that's a quad, they're a passive intrinsic transfer doesn't last. And you rarely have a motor. If you have a motor, for example, you have a flexocarpial narrows, you could motorize an active transfer to give that MP intrinsic transfer. So that's kind of the way we go. Elbow first, extension second, flexion third.
That's great.
And, you can do all that within about less than a year.
Less than a year.
Mhm.
So in order for people to understand, those are the three things that you're looking for during the treatment. What kind of complications are the things that you see the most, and how do you avoid them? And I want to talk about short-term and long-term complications. Can you tell us more about that so people understand and how they can avoid these complications in the future? And also, okay, go ahead. Sorry.
So I think one of the, all the things we've said up to this time, they are so educated, they're so prepared that they have a real understanding. They know how to care for this and so forth. So most of these, there is that chance of a wound infection possible.
Right.
It doesn't happen very often. If they just don't pay attention, they sometimes they could. I had one patient that pulled back on his wheelchair brake like 10 or more years after that and ruptured the tendon in his finger. I had another patient sent to me after the flexor phase that went and grabbed hold of a refrigerator door, pulled that open, broke loose everything. Now, the kind of suturing we're now doing, it's pretty hard to do, but everything broke loose. He ended up going in there trying to repair it, even with a graft. He got infection. He never got it back. So educating the patient, these are things you don't do. This is at the level where you can start giving that strength. And so generally complications, the biggest problem is spasticity. If you're finding spasticity, then you're dealing with potential contracture, trying to balance things, and it can be, you have to really be.
And how often you see that? Because we're talking about open motor neurons that are going to have spasticity no matter what. In many cases, can be so severe. So how often you see that problem with spasticity?
Unfortunately, in the upper extremity for the quadriplegic patient, it isn't very common. When it happens, if you feel like every patient you have has it, because it's tough to deal with. But and it's something you just have to watch for. If it's not too bad, you can.
But they already have it. So you're going to surgery.
Okay.
To have this patient, and then how do you deal with that? Because it's going to damage, it's going to affect your outcomes, and not just that. Go ahead. Sorry.
Yeah, if you do have spasticity issues, your biggest enemy there are contractures. And so as you're doing, you may you're using the neurotoxin injections to cut down the tone, to maintain range of motion. You're be really aggressive on splitting elbow, wrist, and hand.
We're talking about after surgery, correct? Or before surgery?
Or before.
Before.
So if the spasticity, you're dealing with that before you'd ever do surgery.
Yeah.
Now you may need to do some lengthening of finger flexors if they have a lot of spasticity, but I would say results are never as predictable where you're dealing with a spastic extremity versus one that's not. It's a tough.
I'm going to ask you something more specific about that because I see them sometimes. How do you manage expectations in your patients when as despite all your wonderful work, this patient don't get what they want because of spasticity. Some things get out of control. How do you manage expectations of these patients?
Well, that's where you've been working with them all this time, that you've got a relationship they trust. And so you have to anticipate everything that you could tell them this could happen, and what do you want, how do you want to use your hands? How are you going to use for power? Do you want your hands to be softer for using a computer? All of those things are very important to try to understand.
The last question, sorry about that. The last question, I was talking to Marcelo, because this is important. You have a lot of international experience in P&R. Again, like I said, your name is in the building in South Korea. You are the father of rehabilitation in South Korea. So what would be your advice for our peers in Latin America and how to build a hand clinic? I just like you a little bit of background. In Latin America, it's not the same as the United States. They lack the infrastructure, the resources. There are a few countries who are really good, doing well, as far as even Argentina have some hand clinics. There's a lot of countries have hand clinics, but it's different. It's not as interdisciplinary as we are. They don't have inpatient rehab, for instance, all outpatient. So how do you, if you don't have those resources, you have limited resources, how do you build a hand clinic?
Well, if you're interested in doing it, you find out where the spinal cord patients are. Is there any kind of a collection of them anywhere? Usually they are probably located in close to a hospital or someplace where they may not be. But if you can get a person that has the interest, even if they're not the surgeon, they can start this on their own and have one therapist. If they can find a therapist, PT or OT, you can train them. You can, if they go with you side by side, I could take a therapist and I could go anywhere in any country. I did, even in Korea, I did this at several locations throughout the country, and we would get together. I'd say, okay, bring all the spinal cord patients in. You can. We sit there and we just talk with anybody that's interested and show them how to examine a patient and that type of thing. And you can do a tremendous amount of things. And then if you have access to the therapy that can do it, and then have access to a hand surgeon, or even doesn't even have to be a hand surgeon. It could be a orthopedic surgeon has an interest in that, or it can be a plastic. Most of the hand surgeons, they are plastic surgeons, hand surgeons, general surgeons. Anybody could do this. There was a lot of surgery went on long before there was a definition of hand surgery. So, I mean, we did, the original works in hand surgery were not done by, quote, necessarily hand surgeons. So if you find a person that is interested in doing that and you can, they learn the basics, it's pretty basic what you can do. And you can give them function. If you go through these principles we've talked to and do it, the surgery itself, you can do a surgery like that within a couple hours. And you can do it with a block of the arm. And you can do it in pretty simple settings with good technique. So I think all you have to do is find a pairing with a good therapist and say, okay, we are going to talk with you about, and you bring in the spinal cord people and we'll evaluate them with you. That's what I did in Korea. And they brought them in. Anybody interested as a rehab doctor or a surgeon, they're there. We go over it. I go over in detail. I use a chalkboard. We'd examine them. Okay, let's set up for surgery tomorrow. So we'd actually do that. We would set them up. We did the clinic like that. We do surgery the next day. We'd go to another town. We do another clinic like that. So I could go into a country if I had somebody that, say, was a real person that could spearhead for me and take me, okay, here's a location where we know there's spinal cord patients. You get the word out by the media or whatever way you have of communicating. We're going to have a hand clinic or upper extremity evaluation for spinal cord patients at this site on this day. Bring your patients. And You just sit there and go through them, evaluate them, and it'll grow, it'll bloom, it'll happen. And it doesn't take much expense at all. You just have to have the people have the heart for it. And
Then you struggle with the post-operatory. I mean, you always taught me, and I agree with that. You hear this is the rehab part of it. Always the rehab.
absolutely, the rehab part is critical. But if you really are educating them and you can teach them a lot, I've had patients, you know, just in terms of the surgery, never come back. They did well. And I had one just recently, had a deltoid transfer I did. And I had done his other arm 10 years ago. He wanted me to do this other arm. I did it. He came back one time to have sutures out. I never could find him. So I called him. He said, well, I knew what to do. I just did what we do on the arm. It's working great. So, I mean, that's the beauty of knowing these people, because they always have two sides. Most of the time they want the other side done, but sometimes they'll wait. And, but they have to learn all the things you're teaching them to manage their body. And at some point they'll come around and say, you know, what can you do for my hands? But you never keep that out of the conversation from day one. You just start that conversation and you never let go of it, and you gently bring them into it, because to their knowledge, they're going to get all their function back. You know that. And I never discourage or tell them they won't. So then you know, 3 months later, oh my gosh, they can extend their fingers, or all of a sudden they can flex their fingers a little bit. So every little week, month is a milestone in their life that you celebrate. That's the secret of rehab. We're celebrating every day in their life. They're getting better and better. And you are a great example of how you do that. I've seen you work, and your enthusiasm and your embracing those patients is the kind of people we need to walk with them on this journey, rest of their life, or pass it, you know, hopefully pass it, you're passing it on, and when you have your fellow, they're walking with you and they're going out in somebody else's, and they're going to be equipped to do this again somewhere else, maybe a little town in, who knows, Mexico or wherever, but they're going to be equipped, they're going to be excited, and there you go. So you can do this anywhere. Really, it's an exciting kind of thing, because it's just one more element that gives those people the hope they want, they need, and they love you for it.
Well, John, this has been amazing. You know, I love you. I'm gonna miss you terribly. I hope that we can continue having these conversations. I really do. I think I've learned so much from you. I think this is one of the things that I wanted to do for so long, because you have so much knowledge. I don't want that to go to waste. I think
we have the technology now. We can do a lot of this.
And John, we wanted to do this again. This is amazing. I have to go to have patients to see, but thank you so much. This has been an honor.